Did you know women generally have better heart health than men? But once estrogen leaves the room, their risk of heart disease exceeds men? Hi, my name is Anita Kaiser, and this is episode 5 of the podcast series Menopause and SCI in a Hot Flash, where we will talk about cardiometabolic disease and its effects on menopause. Joining me is my colleague Margaret Conquest and our guest, Dr. Mark Nash, a professor emeritus of neurological surgery and physical medicine and rehabilitation at the University of Miami Miller School of Medicine and principal investigator at the Miami Project to Cure Paralysis. He also serves as president of the American Spinal Injury Association. Welcome to the show, Dr. Nash.
Thank you for having me.
So I'd like to start first by having you explain for our listeners what is cardiometabolic disease and why is it a concern?
Well, cardiometabolic disease is a syndrome, and syndromes in clinical medicine are risk factors, multiple risk factors that are usually interrelated with one another. In the case of cardiometabolic disease, there are 5 risk factors. One is overweight or obesity. The second is insulin resistance or diabetes, sometimes called prediabetes. The third is elevated blood pressure. And the fourth and fifth are in blood. One is high levels of blood fats called triglycerides, and the other is low levels of the good cholesterol, which we will call HDL for high density lipoprotein cholesterol. Any 3 of those 5 risk factors confers a diagnosis of cardiometabolic disease.
So you've identified those key risk factors for cardiometabolic disease. Can you share a little bit more detail about the risk factors and if they are modifiable at all?
Sure. Good question. The risk factors, 3 out of 5, confer a health hazard that's the equivalent of a heart attack, even though you may not have had a heart attack, the equivalent risk of a stroke, even though you may not have had a stroke, and also the risk of sudden death. So the constellation or the coalescing of these risk factors is especially concerning. It's also concerning because these risk factors are largely silent. Other than overweight, you may not know you have insulin resistance or high blood pressure or abnormal levels of fats and blood sugar, circulating throughout your system. So the fact that these are silent risks make them even more dangerous. As for modifiable, the 3 major ones in spinal cord injury are overweight, insulin resistance, and low levels of the good HDL. And they are modifiable. They are modifiable by incorporating exercise within the lifestyle, exercise to the extent that you are able, given the impairment, or certainly nutrition plays an important role in many respects. I think it's more important than exercise because you can't exercise enough to offset a poor diet. Treating your nutrition as a medicine is a good approach, and I don't call it diet because it's not a part-time thing. It should be part of the lifestyle. And exercise and certain medicines will increase the HDL or good cholesterol. So those are risk factors that are modifiable. And usually when you lose weight, your blood pressure comes down, so that is also modifiable.
So thanks for that detailed explanation. So I know you mentioned that overweight is one of the risk factors, and I think most of us have an idea of what general obesity is. But what is neurogenic obesity and how does that compare?
Neurogenic obesity is a term that's used to describe obesity or overweight in people who have injury to their nervous system, such as spinal cord injury. It is different from general obesity in that most of the fat mass that is accumulated is around the trunk, not throughout the entire body. And that the fat mass and other risk factors also increase inflammation. And there's a lot of inflammation in people with spinal cord injury. Some of it from their overweight body habitus, some of it from their vascular disease, some of it from bacterial infections, and some of it also from injury to the musculoskeletal system, such as the shoulder. But that makes neurogenic obesity a little different from obesity we see in the general population.
Yeah, it's those quad bellies and parapods that we all complain about that we quickly get very soon, I think, after a spinal cord injury.
I'm asked a lot about how do I lose my quad belly? And the answer is you lose fat mass overall, and that will get smaller proportionally. But there's no way just to target the loss of body fat through physical activity or any other intervention that we know of.
Darn it. So you're saying I can't spot treat my belly fat and still keep good sized boobs.
I'm saying you're great just the way you are.
Thank you. I've heard that women develop cardiometabolic disease later than men. Can you tell me how this risk changes as women enter menopause?
Sure. Estrogen secretion is protective against heart disease. One of its major effects is to elevate the good cholesterol, or HDL, which lowers overall cardiovascular risk. As women enter menopause and the ovaries reduce the secretion of estrogen, that level goes down, and with it goes down the good cholesterol, or HDL, that protects against heart disease. That's one reason. The other reason simply is menopause is associated with aging. And in general, the risks of obesity, the risks of diabetes, and all health risks increase as we age with or without a spinal cord injury.
Yeah, so in addition then to the changes in estrogen levels, how does having a spinal cord injury further impact the risk of cardiometabolic disease during menopause?
Again, the weight gain that's associated with reduction in estrogen production increases that risk factor. The reduction in estrogen also increases insulin resistance and changes the levels of good fats that are circulating in the bloodstream. And all of those contribute to those 5 risks, of which only 3 are needed to confer the diagnosis of cardiometabolic disease.
So it's not just one thing, it's a bunch of things all at once.
Yeah, it's a cluster of multiple risk factors that each imposes on the other and each makes the other one worse. And that feeds back on them in order to create a crescendo, okay, of risk factors that are a greater health hazard.
So we've heard about the classic symptoms of men having chest pain that goes down the left arm. What does chest pain or symptoms related to a heart attack look like in women? And can it trigger AD symptoms? Are there symptoms that may look different if I have a spinal cord injury?
Well, the answer to that is yes. And it's actually one of the health disparities that we concern ourselves with, especially in the spinal cord injured population. Men who are having a heart attack tend to have crushing chest pain, often described as an elephant sitting on the chest, and sharp substernal pain radiating down the arm. Women tend to have a different cluster of symptoms. Their symptoms are less chest related or related to chest pain, and more related to pain in the neck and in the upper back. It's often an absence of chest symptoms that gives concern that this could be misdiagnosed either by the patient or by healthcare professionals in an emergency room when they're treated. As for other concerns with respect to typical symptoms, it's possible that patients with spinal cord injury don't have sensation in the areas in which there is pain, and therefore they don't sense that pain, or their symptoms can be confused with other things as part of their medical profile, such as autonomic dysreflexia. It's not unusual for someone who's having a heart attack to say that they have tingling and numbness in their hands, and this is actually a symptom of emptying your bladder and autonomic dysreflexia that accompanies it. So again, it's more complicated, and we have to be more careful in defining the symptoms and in testing, especially at the emergency room, for risk of heart attack or occurrence of heart attack.
Yeah, I can really see the risk in overlooking the warning signs or symptoms, like especially if, someone is trying to maintain a healthy lifestyle and exercising, things like neck pain or upper back pain could just be interpreted as muscle pain from a hard workout.
Yeah, and you make a good point, and I'll share, very early in my career, we had one of our patients go to a local hospital. It was not a spine center, complaining of severe headache. Okay, and it was obvious as a tetraplegic that he was in autonomic dysreflexia, and their treatment approach was to give him a couple Tylenol, okay, which is not the clinical pathway for treating autonomic dysreflexia when blood pressure is extremely high and risk of cerebral hemorrhage poses.
Yeah. So how would I determine my cardiometabolic disease risk? And if it's high, how could I reduce that risk?
Well, let's go. If we go back to the 5 risk factors: overweight, insulin resistance, high blood pressure, and high levels of blood fats, the triglyceride, with low levels of the good cholesterol, HDL. The blood fats and the cholesterol are determined by a blood sample. So, probably before you saw your physician, you'd present at a clinical lab and they'd take a fasting blood sample from you. In the blood sample, they would also determine your levels of fasting glucose and your levels of fasting insulin. Okay, and that would allow them to determine if there was insulin resistance or abnormalities in your blood fats or your risk from cholesterol. Otherwise, a scale that would accommodate a wheelchair and measurement of blood pressure using a standard arm cuff would be the only other things that a physician would need to diagnose this. And once obtained, 3 out of 5, if they are present, confers the diagnosis of cardiometabolic disease.
And so then what would someone do if their risk was high?
Well, the 2 things we always start with are exercise to the extent that the impairment allows. And it would be good if a patient were to coordinate with a physical therapist or a professional who has experience with spinal cord injury. And nutrition. And I prefer to call it nutrition rather than a diet because diets are usually temporary and nutrition is part of a lifestyle. The nutrition we recommend is a Mediterranean style diet or Mediterranean style program. And we recommend Mediterranean for a number of reasons. One is it allows the user to eat protein less from red meat, more from fish and chicken, but it still allows them to be consumed so that you don't have to make wholesale changes in the things you eat. With respect to the Mediterranean, it's also higher in vegetables, higher in what we call low glycemic carbohydrates, that are those that don't set off an insulin response. And it encourages the use of olive oil and other things that we know from people who live in Mediterranean countries reduces their overall risk of heart disease. The other thing that makes it favorable is that it's not one nutritional plan, it's hundreds of them. And they are modifiable based upon the area of the country you live in, based upon your heritage, foods you ate when you grew up, foods that were prepared by you, by your family. It allows flexibility that some more dogmatic nutritional programs don't allow. And our evidence suggests that you can stay on it, that it's not so difficult to do and unpleasant that after a week or so you give up and go back to your other nutritional plan. Think of nutrition as medicine, and it becomes a part of your lifestyle. And that's the second thing. The third thing is there are medicines to treat insulin resistance, to treat high blood pressure, and to treat blood fats. Okay, and all of those can be prescribed by your physician who has measured these 5 risk factors.
Okay, so when you talk about these different strategies, are there any issues or cautions within those that women need to be aware of?
That's a really good question. As a title of a movie was, it's complicated. One obvious thing to consider in women who are in menopause is replacement of estrogen. Replacement therapy, sometimes called hormone replacement therapy, or HRT. And depending upon the symptoms that women are having, estrogen is the best of the treatments for the symptoms of hot flashes and night sweats. However, it's also the best for bone. However, it also poses a risk when given orally of endometrial cancer in women who have an intact uterus and the risk of blood clots, such as deep vein thromboses, which people with spinal cord injury are already susceptible to. Now, the risk of cancer with estrogens can be mitigated by giving a second drug with the estrogen, and that's called progesterone. So the combination of those therapies is safer than estrogen only, but it doesn't mitigate the risk of venous thromboembolism. For women who are using estrogens for atrophic vaginitis, vaginal drying, giving estrogens transdermally, either with estrogen creams or estrogen patches, is a safer approach, but it doesn't address all of the needs for estrogen of a woman who's in menopause.
Thanks so much for sharing all of these helpful tips, insights, as well as the cautions and things to look out for. So, to end things off, what would be your take home message that you want people living with a spinal cord injury who are experiencing perimenopause and menopause to remember?
Well, preventing and managing cardiometabolic disease is crucial for women with spinal cord injuries, especially during perimenopause and menopause. There's no magic bullet, but a multi-pronged approach has the greatest impact on your cardiometabolic health.
Thank you, Dr. Nash. So if you found today's talk interesting, check out our action planning tool on the website at www.scifragments.ca and feel free to send us your feedback using the survey provided on the website. In the next episode, we'll talk about the risks of breast and ovarian cancer in menopause.